Hi, I'm Dr. Lou Betkin. Welcome to M1 Evidence-Based Medicine for the fall semester. In terms of this podcast, it's going to be what I call a pre-course podcast, just to get you up to speed, where I'm going to spend some time on the logistics of the course as well as a review of terminology. So this course is different from last year because instead of having in-person lectures, we'll have a series of podcasts for the intersession weeks and then an optional discussion group followed by mandatory small group workshops. As I mentioned, I'm Dr. Erica Lou Betkin, and you have my information, email and phone. It's easiest to get to me just by emailing me. This course will operate through Leo, and I'm available by appointment based upon your schedule. In terms of the goals of EBM broadly, it's appraising the literature, assisting decision-making in terms of the individual patient as opposed to the groups that you previously were more focused on in basic epidemiology of looking at groups. We're going to focus on your individual patient that you'll be seeing during a clinical encounter in the upcoming years. So you'll be combining clinical epidemiology as well as your clinical knowledge and skills that you'll be learning in the next 2 years to provide ultimately the best possible care for your individual patient. This is something that you don't need to memorize, and just in terms of looking at the broad educational program objectives that will be covered in this course, both in M1 in fall and spring, as well as in the fall of M2. And you probably are familiar with these. In terms of the course structure, this is something that's different from last year. The M1 fall, M1 spring, and then the M2 fall will be a series of podcasts, discussion sessions, and workshops that will be held for the most part on the Thursday of the intersession week. The one exception is during the endocrine module, where I believe spring break is after that, and the class will be held on a Tuesday. The podcasts are mandatory in terms of listening to those as well as the associated readings. There'll be some mandatory readings and then some that are optional or recommended, and you'll see week by week which ones are mandatory, which are recommended. After that, there's an optional discussion session on the Thursday of the intersession week from 8 a.m. to 10 a.m. So in terms of getting some interactive time, you're encouraged to attend that, but it's not mandatory. And at that point, we'll go into the readings and the podcast in greater depth, and we'll see how what you learned can apply to the medical literature and to the individual patient. And that will be a time that you'll be able to ask questions, and you can link this to a given organ system. Then after that, the small group session, the small group workshop from 10 to noon is mandatory. At that point, students will go over a worksheet based on the module and take a quiz at the end of the workshop, which will be administered on Leo. So please bring a laptop for your small groups. In terms of assessments and grading, this is also new, where a workshop will be based on 100 points. Attendance will be worth 10%. And again, not only attending, but in terms of optimal percentage of points of being on time. Participating in the small group workshop is 50% as well as a quiz, which is 40%. On the quiz, your first time you take it, that grade will be what counts. But you'll be required to take it in order to get a passing grade of 70% or above. So you might take it more than once just in terms of meeting that milestone. In terms of evidence-based medicine, it's become more and more recognized and prominent in medical education with an expanding curriculum. And it's something that's evaluated in USMLE, not only Part 1, but subsequent parts, as well as recommended by the Accreditation Council for Graduate Medical Education for a number of residency training programs. So in the clinical years, this will be increasingly important. As you can see, and I'm sure you're well versed in USMLE by now, there's a number of content areas that are based on epidemiology, biostatistics, and how do you interpret the medical literature. So we will cover these topics over the course of this year and a half that we have together. And again, that's part 2, and you can see ultimately this will lead to clinical decision making, how to interpret and use evidence-based data and make recommendations for your individual patient. So in terms of this specific podcast, I just wanted to introduce you to evidence-based medicine, as well as do a review of commonly encountered types of studies in the medical literature, as well as how you interpret basic statistics. And the relevance of this is, how do you read an article and ultimately apply that to your patient? And the clinical decision-making part is something that will be covered more in the M2 during the fall. So in terms of our outline, we're going to talk about what is EBM, the steps in practicing EBM, as well as basic statistics. And these should be familiar to you from having had epidemiology and biostatistics. So what is EBM? It's a term that was coined by David Sackett, where it's seen as the conscientious, intentional, explicit, and judicious use of current best evidence in making decisions about caring for individual patients. And again, I wrote best evidence because the best evidence tends to change. There's a rapidly expanding literature. With every day comes more and more articles, more and more studies, and about the care of individual patients as opposed to groups of patients. And you can see EBM in this Venn diagram takes the best research evidence, your clinical expertise, which you're learning, as well as listening to the patient concerns. So what would be an alternate to EBM? And I just thought it was something of truthiness, of thinking about Stephen Colbert, of thinking, I'm going to say this because I believe it, of thinking about it in your gut. And that was something, more than 100 years ago, before the scientific methods were routinely used to evaluate practices. Medicine had been based upon expert opinion when it was an apprenticeship of training with an expert and getting a tradition. And the opinions of these experienced physicians had been the best practices. And, again, it was this concept of what the truth is. And there were a lot of old standing medical myths. So again, what we're going to learn is, how do you quantify, how do you apply statistics, numbers, to care at the individual level? So what are the steps of EBM? Well, first, when we see a patient, it might be that a question arises and we want to define that clinical question. So it might be a patient encounter of, you see a patient who has a sore throat that you think is due to streps. How many days of treatment? What antibiotic should I treat it with? With the musculoskeletal module, it might be, relevant question for osteoarthritis or rheumatoid arthritis or lupus, in terms of thinking about a treatment, what you treat it with, thinking about adverse effects, and how long you treat something for. So you would define a clinical question, and then you search the medical literature for studies with the best evidence. And you want to look at relevant studies that provide that evidence. And there's lots of different types of studies available. You want to find studies, again, that are most able to answer this question. You want to perform a critical evaluation or appraisal of the studies to determine the validity of these results. You want to apply that now to your patient. How do those results of that study help you care for your patient and evaluate it? So you would apply that evidence, or you would apply that treatment, that intervention to your patient and see, how does it work? So how do you define a clinical question? You want to be as specific as possible, and we think about the PICO way of defining the population or patient, the intervention, the comparison. Is that comparison another intervention? Is it wait and see? What would that be, and what the outcomes are? So is that death, disability, pain, preventing an exacerbation? So there's all different types of outcomes that you can look at, and that will depend. Maybe 100 years ago with acute diseases, it would be treatment, and now with chronic diseases, it's preventing it from getting worse. And still, of course, we have lots of diseases where, thinking about influenza, gastroenteritis, where you can treat and have that patient no longer have that condition, otitis media. So here's one for otitis media of defining the clinical question. And again, with the case, it's a simple case of 5-year-old with ear pain and fever for 2 days. When examining the child, you find a red bulging tympanic membrane, and you diagnose acute otitis media, or a middle ear infection. So this is something that some of you might have had as a child, or you have a sibling, or a family member who's had a middle ear infection. So simply, what treatment should you prescribe? So the next step 2, would be searching the medical literature. And again, we talked about P, population or patient. And in that, we're thinking about children, in particular 5-year-old children, because 5-year-old children are different than children maybe between the age of 0 months and a year. What's the intervention? Antibiotics. Or a comparison might be no antibiotics, a watchful waiting approach, which is an entirely valid strategy in kids that are 5 years old. Or else you might be comparing one antibiotic against another antibiotic, seeing which one leads to resolution faster or has less side effects. And the outcome would be acute otitis media. And again, how would you measure that? Would it be looking at the eardrum? Would it be seeing when the fever curve comes down? Seeing when the patient is not in pain anymore? Again, step 3, finding studies most able to answer this question. How do we find that best available evidence? Where on our evidence pyramid should we be looking? Should we be looking at case control studies or cohort studies or randomized controlled studies, trials, or systematic reviews? So in terms of thinking about this is just, thinking about acute otitis media, middle ear infection as known by laymen. How does the public obtain information? And you might see this on the internet, you might see this in an article in the newspaper or through social media, Facebook or Twitter. And so this was one that I saw recently of researchers creating an antibiotic gel to tackle ear infections. And that seems pretty good. A one-time squirt of special eardrops one day might replace the ordeal. And so you can see here that on this report, it's been tried in animals so far, chinchillas to be exact. So again, does that extrapolate to your 5-year-old patient? Maybe it's not ready for prime time yet. Maybe it's something, but your patients might be saying, well, I heard about that on social media, and be asking you about that. And again, you want to think about what types of studies do I look at? Certainly I want to look at more than this press release. What type of studies would best answer my question? Which leads you to thinking about, how do physicians learn information? And certainly patients' families, in the case of pediatrics, that 5-year-old isn't necessarily on social media, but maybe the parents have heard about it. And it might be a different way of learning new information, maybe reading a newspaper, depending on how that person, Facebook feed, Twitter, Instagram, how does to laymen learn new information versus physicians? And with physicians, you have to be really critical and scrutinize what you're reading. And oftentimes you might see a headline and you actually will go to the article to see, is that a spin on it? Is that correctly interpreted? Or would I think about that differently? So in terms of reviewing the medical literature, certainly this isn't going to be you in terms of looking at, 1 million published articles per year, because you're busy, you've got a lot of stuff going on, and particularly when you're in internship and residency, you're going to be learning a lot by doing. But you want to be an information manager. You want to figure out how to get that information as efficiently as you can. And you can look at a lot of different databases, Medline, PubMed, PubMed Central, Scopus, Web of Science, and then the Cochrane Library. And some of these, like Cochrane Libraries, synthesize all the studies for you and come up with a report, versus some that are unfiltered, that you're looking through individual studies. So if you look on PubMed and you coded in antibiotics and acute otitis media and children or pediatrics, you would get a very large number of articles. And if you were to take a systematic review, which is a review of articles, and it might be randomized control trials, you can find in the Cochrane review antibiotics for acute otitis media in children. And you can see the background, the methods, a selection criteria where they looked at randomized control trials, and they compared antimicrobial drugs, antibiotics, with placebo, as well as immediate antibiotic treatment, giving a prescription immediately with observing the patient, and if that patient's not doing well or doing worse, giving a prescription for that antibiotic perhaps after 3 days in children with acute otitis media. So, and again, you can see these main results, and you can see that that sample size is quite large because they looked at 13 randomized controlled trials. And again, the combined results revealed that by 24 hours from the start of treatment, 60% of children had recovered, whether or not they had placebo or antibiotics. So again, that's 24 hours. You would want to keep on following that out and see if there's differences in the two groups, certainly. Okay, so not all evidence is the same, and as I showed you a Cochrane review that was a systematic review with a meta-analysis, that's what I would call something at the top of the pyramid, where you're taking a lot of randomized controlled trials or even sometimes cohort studies, taking the best of the best and synthesizing that information and coming with a more precise and powerful result. But you can see as we go down on that evidence pyramid, kind of weaker and weaker evidence, you have randomized controlled trials, which is still very strong evidence. You have cohort studies. So now we're thinking about more observational as opposed to interventional. You have case control, cross-sectional. Then we have case reports and case series. And finally, like that chinchilla study, the animal research, as well as ideas, opinions, and editorials. And you'll see this, all of these published in journals. And you want to be able to figure out how to get the highest quality evidence and to answer that specific question with regard to your patient. And again, as you can see, it's filtered versus unfiltered information sources. So the Cochrane Library, which was sitting at the top of the pyramid, that was a systematic review and a meta-analysis. But you can see some of the resources that you'll be using are filtered, like UpToDate, Cochrane Library, and then unfiltered, where you're looking at PubMed, so you're just seeing a number of different articles that might not have been scrutinized. They're published, they're perhaps peer-reviewed, but they're a bit weaker in terms of the quality of that evidence, Google Scholar. So starting again at the top, we talked about meta-analysis, a systematic review, and a meta-analysis is just a summary of results of randomized controlled trials or observational studies, and where there's a certain procedure that's done where all the data is collected and analyzed together, and you get a summary measure, an odds ratio, a relative risk, a difference that's more precise because you have a lot of different studies combined and more powerful. So that's a comprehensive analysis of all the clinical studies on a given topic. So by combining those studies, it tends to be more objective than a clinical review, which reviews the literature but doesn't necessarily combine that data. And then lower on that pyramid, we have randomized control trials that you might have heard about, studied through epidemiology, which is a prospective study for using randomization, where you're putting patients in groups on a random basis, meaning just by chance alone, to compare the effect of an intervention. So these are interventional studies against the control in human beings. So you want to make those two groups as similar as possible, that intervention group, that control group, and again, that control group could be like the best available treatment, the intervention group could be a new treatment that might be slightly better or have fewer side effects, etc. And you want to see those outcomes with regard to the exposed and unexposed groups, or the control and the experimental groups. And as you can see, this is the design of an RCT. And we're obtaining the sample maybe a sample of kids who have acute otitis media from the population. So certainly we're not taking the whole population of kids with middle ear infections. That would be thousands, hundreds of thousands at any given moment. But we're taking some pre-specified sample with some inclusion and exclusion criteria. We're saying that maybe half are randomly assigned to an antibiotic. The other half might be a placebo or a watchful waiting approach, where if that child isn't doing better or is doing worse, would get a delayed antibiotic, something maybe 1 to 3 days later. And we're seeing disease. In this case, it might be resolution of acute otitis media. Okay, so that was interventional, and now we're going back down on the pyramid to observational, so cohort study. So subjects are defined according to their exposure levels and followed over time, either prospective or even retrospective, where those data already have been collected, to determine the occurrence of disease. So you're looking at people who have some risk factor, some exposure, and you're following them to see, do those people develop or not develop the disease? Or on the conversely, if it's something protective like exercise or taking an aspirin a day or folic acid, are those people who've been exposed less likely to develop that disease? And as you can see, this is not randomized, meaning this population, you'd get a sample of people who've been exposed and not exposed. And again, that sample might be different. It might be, for example, people taking vitamins might be more health conscious. If you're looking at the relationship between vitamins and cancer or MI, and they might be more likely to exercise and less likely to smoke. So in your analysis, you can adjust for that. You'll adjust for those potential confounders that you know about. But those two groups, exposed and not exposed, maybe people taking vitamins versus not taking vitamins, are not entirely equal. And again, you can do some statistical analysis to try to make them equal and get different models, but it's different than a randomized control trial where you're randomly putting people into a group that takes vitamins and a group that doesn't, and those two groups should be equal in every other aspect. Okay, so this is a prospective study that was done last year, and again, you're following them forward in time. Some famous studies are Framingham, Women's Health Initiative. There's been a lot of cohort studies where RCTs aren't possible to do for every single topic. It might not be ethical. It might be something potentially harmful, like exposure to smoke. You're not going to have half of the group smoke. And here's a retrospective cohort study that might have started, let's say, 20 years ago, where you had a population where you had those data collected. So this is something that you might already have that data through kids who've been seen by their pediatrician, and you're getting kids who were just born, and you have all that data from birth to a later amount of time. And you can see that those kids were exposed and then subsequently developed that disease or condition. So you can see the Framingham Heart Study, which has been done for a couple generations now, looks at a number of risk factors with regard to cardiovascular disease and mortality. And there have been a number of papers that have been published, and that's given us a lot of information with regard to the impact of blood pressure, cholesterol, diabetes on different outcomes, both with regard to morbidity and mortality. So some simple pros and cons of a cohort study. You can see a temporal relationship that patients or subjects who do not have the disease are followed in time to see the development of the disease. So you can look at changes in exposure over time. So maybe, for example, if someone's a smoker, it might be that they initially smoked 3 packs a day and then 2 packs a day and 1 pack a day, and so, or exercise. So a lot of times our exposures are things that don't always stay the same. So even thinking about caffeine, some of you might drink coffee and you might drink a lot more during the school year or before exams, and much less during the summertime. You can study multiple exposures and multiple outcomes. So you can do in Framingham, you can look at lots of different exposures asking about diet, exercise, smoking, and outcomes could be an MI, it could be congestive heart failure, it could be death, it could be atrial fibrillation. Once that cohort is established, you can sustain that research productivity over a long time. So the example of Framingham is something that you're following this group for potentially long amounts of time, as long as you have the funding and you have a relatively stable cohort where there's not much migration. With regard to cons, it can be really expensive, thinking about those investments of making sure that you're following up that group. Again, with Framingham, if it's gone on for decades, that can be, you need the researchers, the personnel, as well as large sample sizes. So certainly you wouldn't be following, 10 people to look for cardiovascular outcomes and mortality. And especially if you're looking at people in their 20s, that would be something, if you're following them forward for long amounts of time. It's not really easy to reproduce to get a similar cohort, a different one that's entirely similar. It might be a cohort's done in one country. It might be that Framingham in Massachusetts, that those people are different than another cohort in another area of the United States. And it's not efficient for rare outcomes. So we know, cardiovascular mortality is something relatively common, but if you were going to study a rare disease, you might have to have a cohort of hundreds of thousands of people just to get a few outcomes. So that tends to be something that would be time and cost prohibitive. So going down that pyramid further, we have the case control study, where subjects are defined as cases and controls, and you compare the exposure history. So for caffeine or for smoking, if someone had an MI, for example, thinking about smoking, you would ask the smoker who had the MI, or the person who had the MI, were you a smoker? Did you smoke? Were you not? And then you would ask someone who didn't have the MI, did you smoke? Did you not smoke? And you would compare those two groups. So you'd want to have controls that are pretty similar to those cases, maybe in terms of other risk factors, in terms of gender and age, and other variables. So you can see we are looking at disease, and we're going backwards in a sense of time to see, were you exposed to that or were you not exposed to that? So it's kind of like the chicken and the egg, that we can't say that the exposure happened before the disease, because we have a retrospective bias where we're saying, were you exposed to that? And people are kind of recalling their mind, a recall bias. How much exposure did I have? And maybe people remember things differently. Certainly, maybe if you gave birth to a child who ultimately was found to have be on autistic spectrum disorder, you might remember every single exposure that you've had, or vaccination for the kid, even though we know that vaccines are not associated with autism, but you would tend to recall any Tylenol you took, anything, versus having a child who's not on the spectrum, who might tend not to remember those things as much because that outcome was okay, that the child did not have the disease, or the person you're talking to, maybe with regard to an MI, didn't have the MI. So again, case control, it's easier to find those patients. It's quicker, right? You can go into a hospital, you can post advertisements, so it's a short duration and certainly less expensive, certainly for rare diseases, because of the cohort, as we mentioned, you might have hundreds of thousands of people just to get a few outcomes. And you require a smaller sample size. You can study multiple exposures for one disease by just asking that patient or the control, were you exposed to this? Were you exposed to that? Versus a cohort where you might not even think to ask about, you might not be recording those exposures of interest prior to that person getting the disease. And it's easily reproduced in different populations by different investigators. With regard to cons, it's hard to establish that temporal relationship with exposure before disease. It relies on recall, and we said it can be a recall bias. the question of how do you identify that appropriate control group? Who are controls who are just like your patient? And it doesn't provide an estimate of risks and risk difference, so you don't get a relative risk. So going further on the evidence pyramid further down, these are studies that we don't tend to look at as much for this course, but certainly you've looked at that in the context of epidemiology and biostats, and they're commonly done. Cross-sectional studies are looks at one point in time, and it is very helpful in terms of monitoring the health of a population, either with regard to your patient population, population of people in New York City, or the U.S. And it's just one point in time. Do you have diabetes? Yes, no. What's the mean hemoglobin A1C for this group? You can get a lot of information. It's easy to conduct and inexpensive, can be done quickly. But it doesn't, if you ask someone, do you have this? Yes, no, it doesn't have any explanation of cause and effect. And again, finally, we're not really going to talk about case reports and case series. In the, 80s, with regard to HIV, this was something that the first case reports of men with Kaposi sarcoma came out. Maybe a disease like West Nile or Ebola might have case reports, case series. Often it's the first description of a new disease, a clinical sign, symptom, treatment, or diagnostic test. And again, it's easy and inexpensive, but it doesn't provide those explanations of cause and effect that we find as the useful evidence. Okay, so we've really gone over the tree, but we want to critically appraise that study, maybe that systematic review, that randomized control trial that we were looking at back to acute otitis media. We're going to determine how the results will help you in caring for your patient, and then finally evaluate the results of applying that evidence to your patient or patient population. So think about it. It might be that your patient has a penicillin allergy and the parents, this is the patient with acute otitis media, want to avoid antibiotics at all costs, even though there's lots of different types of other antibiotics that you could give that child. But it's really important the parents say, that child's had these symptoms before. They tend to go away in a couple days. And, please, I just would just make sure that it's just acute otitis media, and just giving adequate doses of Tylenol or a nonsteroidal. And so again, patients or patients' families might have different opinions with regard to a treatment for a similar condition. Okay, so this should be reviewed to you in terms of additional terminology for how to read the literature. So thinking about this population and sample, the population is everybody. It's a set of all possible members of a group being studied, but we never look at that. We tend to look at a sample, which is a subset of this population that's chosen for a specific reason. We might use a sample, a convenience sample. So some of you with EHS, with your fieldwork, you might have sampled a convenience sample, people that were in the waiting room or in the clinic. And we do that out of convenience or time, cost, logistics. And they may or may not be representative of the entire population. It might not be a random sample. It might be a sample of people at a given day when you were doing your field work that were in the waiting room. So in terms of looking at distributions, you'll most likely be familiar with mean, median, and mode. And we think of these as central tendency and averages, but in clinical medicine, we tend to look at the mean. And you can see with regard to distributions, most tests or results don't tend to have a perfectly normal, bell-shaped curve of a normal distribution. And you can see in the lower parts, you can have a positively skewed distribution or a negatively skewed distribution. So thinking about a positively skewed distribution, you can think about weight, where, you can't go below a certain level. But as you go further and further, different classes of normal weight. So you might have some underweight, and you might have normal weight, overweight, and then class 1, class 2, etc. of obesity, you'll have this positive skew where fewer and fewer people will be in the higher classes of obesity. Or on the converse, you might have a negatively skewed distribution where, for example, hemoglobin can't be above a certain value, but some people could have an extremely low hemoglobin, people who are anemic, maybe had GI bleed, so their hemoglobin might be 6 or 7 or 8, up to some point. And you can see, again, in clinical medicine, these distributions where you can see total cholesterol, and you can see from that, we break down total cholesterol into LDL, HDL, and triglycerides. And you can see that HDL is actually a protective factor. It's like a positive risk factor, where it's good to have high HDL, but it's not good to have high LDL. And both of those are input into your total cholesterol. So how do you describe a distribution? You can see it's measures of dispersion where we have a range, the lowest to the highest. We can have quartiles and percentages. And you might be familiar with this with regard to taking a test and having some percentage or some quartile variance with regard to how far the data spread out. Standard deviation we use a lot in clinical medicine, which is looking at the amount of variation or dispersion of a set of these values, and standard error of the mean, of how far the sample mean is away from the population mean. And we also have variation. So you look at these bell-shaped curves, right? And you see there's different sources of variation. So variation is normal, but you also want to think about that in clinical medicine with regard to the instrument that you're using, as well as the variation of the patient. So we know when we measure blood pressure, we're going to measure it more than once. We might measure it at different times of the day. We might even ask the patient to measure it at home or under different circumstances, or even get a 24-hour monitor. So you can see, with regard to measurement variation, one patient, one observer. So when you were learning how to take blood pressure and you observed it at one point in time, so there's no biologic measurement variation where you're just doing it at one single point of time and you're getting a value. So you might do it 3 different times really in the same 5 minutes just to practice. And your values are probably very consistent because presumably you're doing it correctly, right? But it's just you listening. But if you are learning and your friends are also learning and you might be listening to the same person, there can be one patient and many observers, and you'll have more variability because your friend might might get a slightly different reading, might hear it a little bit differently, but you're looking at one time point. So thinking about that dispersion, that bell-shaped curve is a little bit wider. As well as when you add biologic variation, and that's something that's very important. Blood pressure has a circadian rhythm, tends to go up a bit in the morning, maybe lower at night. If someone's in pain or stressed, it will also go up. And so again, thinking about that, how that varies with circadian rhythm, as well as moment to moment, it might be different for you with regard to if you're taking an exam, if you've stayed out late, even if you've taken caffeine. So thinking about one patient, one observer at many times of the day, there'll be a bigger distribution, as well as many patients at many times of the day. And this is for diastolic blood pressure as an example. And also with regard to clinical measurement, we think about data, how when we look at an article, they're going to analyze data in different ways according to what type of data it is. And maybe you're familiar with chi-square tests, t-tests, maybe even done some regressions. And so for a nominal variable, you would use a chi-square test with regard to sex, blood type. So you have different categories that don't necessarily have some sort of scale to it of taller, tallest, or some sort of distribution or ranking. But nominal data, so sometimes we talk about data as being nominal when we talk about male or female or blood type, of having a category, or even thinking about non-medical of a car, different types of cars, different types of brands of something, right? Then we also have ordinal data, which doesn't have a linear scale. It's not something, but it has this. So thinking about staging of cancer, heart murmurs, the intensity of it, how we grade it, categories of hypertension, where we're not saying, stage 4 cancer is twice as worse as stage 2. It certainly has a very different meaning, and the prognosis is worse, or a stage of hypertension, but it's not twice as bad. The number of seizures, right? So 4 seizures is not twice as bad as 2 seizures, as well as interval data. And so we can analyze that and ordinal using t-tests. And we can look at intervals. So someone who's 30 years old is twice as old as someone who's 15. There is some interval to that. Someone who weighs 300 pounds weighs twice as much as someone who's 150 pounds, as well as temperature. So those are 3 different types of data that we will talk about, and certainly you'll see with regard to when you read these articles. In terms of performance of the measures, we talk about validity, which is accuracy, which is the degree to which these data measure what they're intended to measure, as well as reliability. So the extent to which you repeat those measurements by different people and using different instruments, kind of thinking about the blood pressure at different times gives similar results. So ideally, you want your measure to be valid. You want that blood pressure cuff to measure the true blood pressure. And the gold standard might be an arterial line, which is something that's invasive and sometimes used in an intensive care unit, but we don't use that in the ambulatory setting. We only use that when someone's really sick. We're using another measure or instrument as a proxy for that gold standard, but we want it to be valid. And we also want it to be reliable. So if we're going to take blood pressure over time and the blood pressure doesn't change, for example, in some artificial circumstances, someone who's calm and cool and it's kind of relatively the same time of day, we want to get that same value. So we want to get the true value, validity, and we want to get similar values. So I tend to think of that as a target where ideally you want it to be accurate, valid, and reliable and precise, right? So you want to get the bullseye of the target. So you wouldn't use a test if it's not accurate and not precise, because, so for example, think about standing on a scale. It might be that sometimes if you weigh like 150, sometimes the scale would say 170, sometimes it would say 140, sometimes it would say, 12, like something totally random. So you wouldn't use that scale. It could be not accurate and precise, where if you weigh 150, it could always be 130. Well, that's not very helpful either. You'd have this false sense of, hey, that's terrific, I guess, if that's depending on your height. And again, there could be the accurate and not precise, where, on average, if you're 150, sometimes it's 140, sometimes it's 160. But ideally, you want your measurement to be valid and reliable. And so finally, in terms of thinking about other terms, the prevalence, these are things that you should know, is the percent of a population with a disease at any given time. So it's the number of cases existing and new over the total population at risk. So we'll often use the word prevalence, and that's different from incidence, which is the new cases of disease for a given unit of the population in a given unit of time. So you can see that prevalence in general, it equals incidence times duration. So there might be that certain acute diseases like influenza that have a short duration, the prevalence might be relatively low for a high incidence. Or it might be that a chronic disease with a relatively low incidence, that person might have that disease for a number of years and the prevalence might be high, even though it's not especially common disease, but you have it for a long period of time. So this is the pre-podcast. I'm hoping that a lot of this information was a review, and I will be doing another podcast with the first lecture. So, okay, take care.